Good old cookie cutters. A little 50-piece set with a bunch of animals. Our little guys have been playing with these things, been getting curious and wanting to carve into some Play-Doh. Got a tiger and an eagle. Got a lion. I love the mane of a lion. Got a turtle. We've got Maverick loves turtles. What else do we have here? Looks like a little caterpillar. A squirrel. Man. Got some good stuff. A kangaroo. Wowzers. These cookie cutters have the potential of some great moving skills as animals that we as human beings could really enjoy and apply to our fundamental skill set. The medical world today resembles oftentimes these cookie cutters. These cookie cutters in which a bald eagle is a non-customized thing in which every bald eagle looks the same. And unfortunately in today's medical world, we in all paths of this field, we treat people as if they're a cookie cutter. We give them a medical diagnosis, we give them a rehab diagnosis, and we run with it. We lump them together with everyone else that has what they have, and we begin treating them that way in terms of rehabilitation. We start talking to them in that way, and we start labeling them. And the problem with this cookie cutter approach, a lot of different problems with that, is that it's a very demeaning and a very mindless and a very thoughtless way of, first of all, doing our jobs, and then second of all, giving this individual what they need. We neglect their story, we neglect to hear them, and pay attention to what they're telling us. And big importance with that is that although yes, in terms of figuring out what the patient, what the individual has wrong, we need a rehab diagnosis. We need a tissue-specific impairment, but most importantly, we need to know what's causing it and where it came from, which is much more difficult to figure out. But unfortunately, in this world we live in today in the United States, we start labeling people and cutting them out and putting them into this medical diagnosis for the purpose of billing, for reimbursement. So we start to get, in regards to cookie cutters, we start to get facet syndrome. We start to get rotator cuff syndrome. We get shoulder impingement. We get cervical spine impingement. We get degenerative disc disease or degenerative joint disease within the facets of the spine, cervical or lumbar. We get lumbar or cervical spine stenosis. We get cervicalgia. We get lumbago. We get spondylitis, spondylolysis, spondylolisthesis. We get a femoral acetabular impingement. We get a little rectus femoris tendinopathy, tendinitis or tendinosis. We get a little patellofemoral syndrome. That's a good one. We get a little carpal tunnel. Interesting little shapes, trying to figure out what these guys are. We get a little quad strain or a little knee pain. We get some hip pain or maybe a little greater trochanteric bursitis. We get a little lumbar spine strain or sprain. See, the unique thing about these cookie cutters, in terms of what we're laying out, and some great mentors of mine at the Gray Institute have always, and for the last 15 years that I've known them, have talked about how a protocol, the imprisonment of protocol, so protocol becomes imprisonment, vice versa, and the encouragement and the empowerment of customization. So again, I'll reiterate that it's really important to have a rehab diagnosis and a tissue-specific impairment, something that we know specifically why the individual is coming to us, but more importantly, why and how they've gotten to this point. So cause and effect. When we start looking at individuals like cookie cutters like this, when they come to us and they start referencing an anatomical location, a spot on the body, instead of listening to and facilitating good conversation to bring about what actually is taking place, which doesn't take very much time, maybe 5 or 10 minutes, we start to automatically assume that this individual is presenting with a location and symptoms that are consistent with what we've seen in a textbook. Although there has to be criteria that matches and brings together with conclusive evidence, best exam findings to point us at what the rehab diagnosis is, what the tissue-specific impairment is, we need to do a great job in terms of our differential diagnosis. We need to be able to be great diagnosticians with regards to knowing if what we're doing and what we have with this individual that's come to us, if they're within our scope of practice, meaning do they have something that is treatable by us, no matter what profession and no matter what field that we're in. And the danger we run into today is that once we start throwing these labels around and only have brief conversation with that individual without facilitating greater conversation with them, we start using these labels, and in between a variety of clinicians that are maybe involved in this case and in helping this patient, we then oftentimes find that we don't have clinicians that that are willing to proceed with their own findings, to dig deeper, to put these biased opinions away with what they've maybe potentially seen. And there's not enough courage that is put forth in maybe disagreeing with what others or what someone else has said in terms of what somebody has. And we need to be very careful that we don't strip someone of their identity. And placing someone in a cookie cutter, a cervicalgia, which basically means neck pain, could be 20 million different reasons for it, not 20 million, but maybe 5,000 reasons as to why that is, and maybe hundreds of reasons or dozens of reasons in terms of what it actually could be, tissue-specific and rehab diagnosis-wise. We need to do a better job of playing the game if we're in a non-cash-based system, and even a cash-based system when we're doing out-of-network stuff, because obviously there needs to be amongst this assessment good conclusive evidence for the sake of reimbursement. And a patient, first and foremost, they need to know. We need to give them an answer in terms of what they have and how it was created and why, where it's coming from, where's the root of the problem. But we need to be really careful that we don't strip the individual of their identity. And this is what a cookie cutter does. It places them in this little baby seal. So instead of treating John and Timmy and Bob and Joe Mark and Matt, Melissa, Michelle, Carol, all is the same baby seal. We need to say, hey, we recognize your story as being very important. We recognize you as being an unrepeatable human being that has fingerprints and footprints that will never and have never matched any human being that will ever roam amongst the history of this earth, that will ever have anything quite genetically quite like you. We have a great deal of respect for your story, for your goals, and for your passions to live a purposeful life, occupationally, recreationally, amongst your family and friends and amongst society. And we're here for you to help you in the process of maximizing your genetic potential. And we're here to help facilitate and close the gap on what your genetic potential is. So, although for the purpose of telling you what you have, and for maybe medical purposes for billing, this is what you have, we owe the patient and as a patient's right, we owe them the opportunity to have them be treated as if it is our mom or dad or grandma and grandpa, our brother and sister, or our best friends. We are better than a cookie cutter. Our patients are better than a cookie cutter. Our skills are much better than a cookie cutter. We need to take pride in our work. We need to take pride in the fact that we can think and act and strategize and provide tactics that are uniquely different than anybody else. We need to trust that process as professionals. A cookie cutter. I always, especially around the Christmas time season, as that was a big time in our household in terms of the gingerbread man, the Santas and the Rudolphs. I always today, when I see cookie cutters, I think of how we place a human being in a box. We limit them. We place a great deal of restrictions upon them, and we don't listen. We can't assume that this little cookie cutter, which is relative to the individual that comes to see us, is just that, a cookie cutter. We need to not have a biased opinion, and we need to go with the mindset that, you know what, prove to me that you don't have what I think you have. After hypothesizing amongst our conversation in regards to a tissue-specific impairment, and then, hey, not everybody, in terms of your tissue-specific impairment, in terms of the strategies that you need to have and the techniques and the tactics that need to be implemented, not everybody needs the same thing. It's the most demeaning thing ever to hand to a patient or an individual that simply wants to get better some sheets of paper that says, hey, here you go, take it and run with it. I love it when I get that stuff from physicians with regards to hip and knee replacements, spinal fusions, tendinopathy, shoulder replacements, slap tears and lesions and rotator cuff repairs. Basically says we don't give a crap about the patient. We really don't have a whole lot of trust and faith in ourselves and in a physical therapist or other clinicians that's using movement as an intervention to create and facilitate healing to get that individual back on their feet and close that gap on what their genetic potential is. We need to do a better job of trusting the patient in all areas of the medical field. We cannot judge and place a human being in a cookie cutter so that everybody gets the same exact watered down thing.